Hello, good morning. I'm Ashok Rokade, consultant rhinologist and Andreas Skull Base surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Andreas Skull Base Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So may I welcome Dr. Troy Woodard. Troy is from Cleveland Clinic. It's a very privilege to have you, Troy.
Thank you.
We'll start hosting Jim. So
okay.
shall I hand you over?
Yes, so it's an honor to introduce a good friend of mine, Dr. Jim Palmer. He's professor of Otorhinolaryngology and director of the Division of Rhinology at the University of Pennsylvania. He's also co-director of the Penn Center for Cranial Base Surgery, and he's past president of the American Rhinologic Society. Today he'll be presenting a lecture on revision sinus surgery. So I'm going to hand it over to Professor Palmer.
Troy, thank you so much. So great to see so many faces and friends. I would far rather be together right now in some lecture hall and then afterwards going for drinks. But instead, you can see I'm wearing my scrubs. As soon as I'm done, I'm going to the OR. I much prefer visiting all of you guys in all of our group in fun places. And so everyone, I'm waving to you all. Ashok, thanks for all the great work getting this set up. I'm going to start sharing my screen and off we go talking about revision surgery. Are you guys getting my screen?
Yes, we got your screen.
Perfect. Okay. All right. So we'll talk about revision sinus surgery for the next half hour. Disclosures, the standard ones, agenda. I want to convince you that the role of ESS in most situations is to open the sinus cavities to allow irrigation and placement of topical therapies. Convince you to either do complete surgery or don't do surgery at all, especially in the polyp patient. And convince you that topical steroid therapy and care of the CRS patient is lifelong for success. Now you're saying, wait a minute, Jim, this doesn't really sound like revision sinus surgery. Except that I want to ultimately convince you there's not really a role for revision surgery because you should have opened it all up the first time. So, quote from an album for those of you that are a little bit younger than I am, Billy Joel, The Stranger, one of the songs on that album that came out in 1977 was "Get it right the first time, that's the main thing." And I will not make you all have to listen to me sing, but play that at some point in the OR for your fellows or for yourself, to remind yourself that do it right the first time. All right, let's talk about FES failure. 80 to 85% success rate. I would like to think it's higher than that. The more experienced you are, a bunch of FES is done per year, at least in the US. That's a lot of failures. But I think the number of failures are actually much higher in the patients that do okay, but they're not significantly improved because maybe they shouldn't have been in surgery in the first place, or maybe they didn't get a complete surgery. Let's not fight over that. Let's talk about the two ways I think about surgical failures. One is poor surgical technique. Did you leave a residual uncinate? Do you have mucociliary circulation because you have scarring either before or after surgery? Lateralized middle turbinate, failure to keep a sinus open, frontal or sphenoid. That group gets revision, but I wish they didn't. I think that's obvious. The next group, not performing appropriate surgery for patients who need topical access as a primary goal. And then we have to throw out those that didn't need surgery. So if you're thinking about it that way, it really comes down to topical access, which helps you make successful, which makes you not have to do revision surgery. This is my own patient, I have to admit. Years ago, 0-degree scope, little pus flowing, 30-degree scope, little pus flowing, 70-degree scope, little pus flowing. Oh boy, I blew it. I cut that in the office. Patient does better. Little tip for me, after this case, at the end of every case, I've got the 70-degree scope to look at the frontal sinus and make sure I'm happy with it. I also turn the 70-degree scope to the side and check out that anterior edge of the maxillary ostium and make sure I am not setting myself up for this. This one may have been fine in the OR and then that scar grew in the office. Doesn't matter. I cut it in the office. One of the things to think about. So what do we know about surgery in general? And this is for all patients. CRS is a medical condition we used to think of as infection. It's really inflammation. That inflammation is due to infection, due to environmental exposure, due to innate immunity response. So how do we combat it? Oral antibiotics, corticosteroids, and topical therapies, which we'll keep talking about through all of this. So in some ways, revision sinus surgery in me is actually more a lecture about irrigation maximize endoscopic sinus surgery, because if you can do that well, you don't have to do revision surgery. Isn't that nice? People to thank: my partner, Nithin Adapa, the crew at the Rhinology lab that helps us do that. There's Noam Cohen, Brad Woodworth in a younger day hanging out. I always put this in the slides, Brad, if you're listening, just so you see that. And then I know Richard Harvey talked earlier. This is Richard in his younger days demonstrating just how great the NeilMed bottle works, except that he's doing it wrong, as I love to point out. If you notice, he's smiling, but he's putting it in on the angle, slamming it into his septum. Get it at 90 degrees to the floor. If you want to have your patients know how to irrigate, get on YouTube, PENN space Rhinology, Penn Rhinology. I will magically appear and talk for like 10 minutes about how to irrigate. And I'm kind of silly, so hopefully it'll create some laughs. Okay, so let's get on to revision surgery and surgery in general. CRS, a disease of poor mucosal clearance. Two groups: loss of mucosal clearance, secondary congenital or traumatic cause, mucocele silent sinus, ventilate. So if that's your problem in revision surgery, you're ventilating those, fine. But that's really not what we usually see. Poor mucosal clearance due to inflammation from either systemic or local cause. They need to be ventilated, but they need to continually wash to decrease that inflammation. Here I am in the Dead Sea demonstrating saline's great. It also makes you float in the water. So, philosophy and evolution. Primary people for me now don't get surgery until very aggressive medical management is completed. I will describe that for you. Revision surgery. If you go to the OR after you've had one shot by me or somebody else, everything gets cleared out. But then again, almost all my primaries, everything gets cleared out because I want to be able to place those topicals. Send me an email if you want my topical recipes. So, jokingly, for me, especially for polyps, but also for all sinus surgery, I have evolved. Some people would say maybe I have devolved. This is Pete Papagiannopoulos and Charles Tong, who are my fellows a couple years ago, and they used to jokingly say that they could tell you when my first surgery was on patients based on what it looked like in their nose. 1.0 about 2007, 2.0. This is after Choose left and I'm sort of on my own, and then Adapa begins. 3.0 in the period to about 2014, 4.0 or 24. So endoscopic sinus surgery for me has evolved to more complete, or is it just I'm changing the surgery to allow placement of disease modifiers to keep the local inflammation in check? So if we keep talking about this strong pro-inflammatory origins, we'll do a case. 45-year-old male, 3 previous sinus surgeries, now with nasal obstruction and polyps. 2004, there's his surgery with me. Full of polyps, full of disease. I take him to the OR. I give him a 1.0. Bilateral all 8 sinuses, full frontal recess dissection, septoplasty if needed, middle turbinates preserved. Post-op, prednisone taper, Nasonex nasal spray, plus nasal irrigation. So I did him in 2004. He immediately gets better. Steroid nasal spray, saline irrigation, subsequent 4 years, starts to go down the tubes. Here he is in 08. I thought I was a good surgeon. I don't look very good in 2008. A lot of the disease is returned. I like to point this out. This is a national audit in 06. Claire Hopkins, you'll notice, led that look into the disease. Revision surgery, all patients, 11% at 6 years. We should be better than this. Across the board, we should be better. How do we get better? We make sure we do appropriate placement. We do our surgery so our topicals get in. If our topicals get in, the patients do better. So this is revision on this patient. He's now in 2008. He's now 10 years out of his last surgery. Small sphenoid, because in that situation, no sphenoid disease. Admittedly, most of the times I open up that much more. Going up to the frontal, beautiful, wonderful, looks great. There is scans in 08 before he had surgery. Here he is in 18. That's what you want to get. What did I do to make such a difference? Pulmicort nasal irrigation. Started doing them somewhere around 06, 07. Evolved into doing it because I was dripping steroid into the nose in Meigen's position. Said, why not? And also having them irrigate, why not put it in the irrigation bottle? Alex Chu and I sort of pioneered this idea. Richard grabbed it and ran with it and made it into something. And it really is making a difference. So what's Palmer 2.0? 07 to about 09, 12, post-op prednisone taper, budesonide irrigation. Makes a massive difference. And there's lots of articles. We can find it from everybody. But bottom line, meta-analysis, pooled data, it works better. Thank you for publishing that, Richard. On blockage, on endoscopy, on radiology. Bottom line, you should be irrigating with steroid. So let's get back to philosophy. Primary, we haven't talked about primary, that was revision. Okay, worst kind of patient you can ever have come see you, it's my wife's friend shows up in the office, right? 4 to 6 months of symptoms, multiple 10-day antibiotic courses, short courses of oral steroids, no irrigation, nasal steroid spray. This is her CT scan at the visit. You look at that, you're like, man, now I got to take my wife's friend to surgery. I'm going to be getting calls via her all the time. If you look at these scans, plenty of disease. You can convince yourself the bone is thickened here, so on and so forth. So what do I do with her? I try to get to avoid operating on her for obvious reasons. 4 weeks levo, BID irrigation with steroid, large prednisone burst, bring her back 3 months later after treatment. Look at those scans. They are pristine. She's got a bad septum. If I wanted to straighten her septum, fine, except that she's had her deviant septum for 20 years. It can't be that bad. I now don't have to deal with operating on this patient. So if you want to operate for the sake of operating, fine, but they need intensive medical therapy first, because a lot of these people will get better if you clear things out in a way to allow their normal mucociliary clearance to return. And this lady's actually a super taster. That's a whole nother kettle of fish that we can talk about at another surgery. So what about people who need to go surgery? For me, when I'm thinking about surgery, this is revision and primary. I kind of see them as the same thing on some level. I don't do surgery, so stuff that can drain out, because they get better with aggressive medical treatment. We talked about this. I now do surgery so I can put therapeutic topicals in because their mucociliary clearance is damaged and needs augmentation. How did I get there? Well, you saw that first case. Here's some other ways to think about it. David Kennedy let me borrow this slide, or actually, I guess I own it now. Here's his picture talking about, this is his first endoscopic sinus course after draft, and he's given a talk, and back then talked about the osteomyel complex. If the osteomyel complex was blocked, everything was bad. You open it up and everything gets better. And so the goal was to disturb the sinus as minimally possible to get back to natural function. And he would go over mucociliary abnormalities, anatomic abnormalities, parquet deposition, and so on and so forth. Look over here, persistent localized inflammation, really important. He was right in 1985, he's right now. That's the problem. So what did that mean back when David was giving those first lectures and we were all talking about sinus surgery and how it was revolutionary? The idea was the OMC was the linchpin in clearance of disease at this point would restore natural drainage. PJ put out an article a while back that you got to be greater than 4 millimeters to get the irrigation in there. So what I want to point out is I think what we're dealing with is persistent localized inflammation that is the problem everywhere. So when you say localized to just the osteomyel complex, do surgery there, and maybe a few years later, your persistent localized inflammation further back, further back, further back. And so the localized inflammation being nasal cavity is your problem. And we've actually been right all along. It's just what area are we talking about? So whatever the function of the sinuses are, they have to self-clean. So if they're not cleaning on their own, we need to help them clean with our topical irrigation. So that gets us to 3.0. 09 to 12 to 2014, roughly. Middle turbinates removed to varying degrees. So our group in France that talks about nasalization. Here's one of their papers. At 5 years, nasalization, middle turbinate removal plus removal of mucosa down to periosteum, 22% recurrence, complete ethmoidectomy with middle turbinate preservation, 58% recurrence. I'd like to have no recurrence. Let's get down to that. And I think you can help yourself get there if you can get them irrigating. So I will take those turbinates if I think they are blocking the ability of steroid irrigation to get back into the areas of the posterior ethmoid, especially when those turbinates are really big, even with the tear duct. We've all seen that case where it's just super tight up there. just go ahead and cut them back. Make some room for the irrigation to get there. You're going to be happy. Case EL, 55-year-old female, no previous sinus surgeries, now with nasal obstruction polyps, prednisone, irrigating with budesonide. Here are her scans pre-op 2016. She's just completely full house blocked. Here are scans 3 years out, post-op 2019. So we're going to look both endoscopically in her nose and at her scans. Let's look at those scans again so we can just cheer. Yay, this is what we want with these patients. So she got all her polyps cleaned out. She got all her sinuses cleared out. She hadn't had surgery before. Let's go back to that and see that this is primary surgery. So what I'm saying is, make sure that irrigation can get there, especially in your polyp patients. Now, I didn't do a draft 3 on her. I didn't need to do a draft 3 on her. Why did I not do a draft 3 on her when I talk about draft 3 so often in these bad disease? What I want you to notice is in her frontal sinuses, she has just one small opening and then it's wide open. There aren't little individual cells, especially in interfrontal sinus septal cell. This surgery is not about drainage. This surgery is about allowing irrigation to get there. Okay, I think I've beat that horse a little bit, almost till it's dead. I will kill that horse before we're done. Palmer 4.0. 2014 to now, bilateral all 8 sinuses cleared, upfront draft 3, septoplasty if needed, middle turbinates trimmed, and then budesonide irrigation plus or minus Xhance. Xhance is available in the United States. It will be available internationally at some point. It's a spray that actually delivers steroid to the farther areas of the ethmoid. And basically what I say is steroid up your nose 2 times a day. So let's talk about irrigation. Can we model what happens in irrigation? We took the U.S. Geologic Survey computer programs, modeled the airflow, created a CFD. This isn't so novel anymore. Kai Zhao, John Craig did this for me around 2014. Here is a picture. I got this at a antique store in Jaffa from a German ENT book. We've been irrigating since the 1850s or earlier. So this is good. We should irrigate. So these guys put this next set of work together, looking at how to irrigate your nose. This is our computer flow dynamics model, no surgery. And then let's go through a patient with a case, 34-year-old man, nasal polyps, nasal obstruction, severe frontal headache, lots of disease. Took him to, here he is, irrigating before surgery with our CFD model. You can see that if you haven't had surgery and you have a lot of blockages, no surprise the irrigation doesn't get to all the sinuses. Draft 1, just going up to but not into the frontal sinus. I never do that, but I do always want to stop and thank Wolfgang Draft. What a great person, and so always interested in, whenever he was at a course, in a meeting, anything new you were trying, he would be so encouraging and such an exciting person. And I really want in my career to follow that model. So when you come see me at meetings and I'm encouraging, know that I'm just trying to model myself after Wolfgang. Draft 2A, going up to, but into the frontal sinus itself. 2B, taken off the floor. And so let's talk about this guy. So remember, this is 2004 when I first did his surgery. I took him to surgery, draft 2A bilaterally. Daily irrigation with saline and nasal steroid spray, severe frontal headache, episodic, needs antibiotic and steroids 3 to 4 times a year. I get a new scan on him. Look, there's still some junk up here. I got into both frontals, as you will see with my 70-degree scope in the office. I did get him drained, but I did not maximize him for irrigation. So you can see I got the top off that type 4 frontal cell over there, and we're going to look on the other side and see more of the same, that I was able to get into every sinus. They were, quote, drained, for lack of a better way of saying it, but he was not better. He still had his episodic infections and issues, and it was because the steroid wash was not getting to the sinuses. And here again, drained, but still has episodes of disease. 3 years later, put him on budesonide, because then in my evolution of life, I was using budesonide. He's still having symptoms, but less. New scan when he was at his worst. This is 2011. You can still see some blockages. Should have I done draft 2A versus draft 2B? So, well, the reason why I like to show this slide, this is a different patient, and the reason why this one worked is that for this patient, there was an interfrontal sinus septal cell on the other side and no other disease. And so she got a draft 2A on her side that was just one big wide open sinus, and a 2B to drain that interfrontal sinus septal cell. I will either do a 2B to drain an interfrontal sinus septal cell, or I'll just go to a draft 3. So draft 3, Wolfgang shows up again. I love this one because that woman has so much cool makeup on in my office, but we're going to take a look. Here's a draft 3 that really cleared out everything. This was multiple surgeries for her, and that is what you want to be at the end of that surgery. So this is that same patient, 2011, still got some junk. I'm not going to belabor and force you to watch me do an entire draft 3. I'm going to work my way along because those lectures have been covered before, and let's get on up to where you want to be. You want to get every last partition all the way to the top. Don't believe it when people tell you, oh, it's okay to just do a little bit and have a wash over at the front. Get it all, because this is your shot. Make sure you have that big, wide open horseshoe, both sides, all the way to the top, so the irrigation will get there. So now he's 8 years post-surgery, doesn't need oral steroids or antibiotic, no episode infections anymore. He just does pulmocore irrigations, maxillary, ethmoid. Never really opened up a sphenoid because he didn't have disease there. And then we're going to turn with our 70-degree scope and look up top, and there we are. All right, we're going to go on the other side too, make ourselves feel good. That's what you want the frontal sinus to look like after your draft 3. That is going to do well. No more revision surgery, thank God. Get it right the first time. Okay, so visiting Turkey, I'm in Cappadocia. Look at all those little partitions. That's not what you want. That's before surgery. After surgery, that's what you want. This is the original. Over here, this is a house from the 60s, and over here, you just created an open floor plan. Take all those walls out. So pre-op, let's watch the irrigation go up, and this was a revelation for me. So this is 2014. We make this study on these old films. You see the irrigation's not getting to the frontal. Here we are, post-op draft 3, whoosh, right through the frontal sinus and around. That's splashing across the choana. So when you do a draft 3 and you put your head 90 degrees to the floor, your irrigation goes preferentially through the frontal, and that's why a draft 3 works when you need it. Let's watch that again. That's so much fun. So let's watch the irrigation go around through that area. This also makes me say to patients, oftentimes I say we're irrigating, but realistically what we're doing is flooding the sinuses. Because you're flooding the sinuses, I thought it shot up like a fountain here. It banks off so many areas in the sinuses. It's really a flood. Okay, so for topical therapy success, I'm visiting Cambridge. Think of myself punting on the cam. If you tried to irrigate down the cam, you're running into all those knuckleheads blocked, fiddling around. You don't want that. What you want is like King's College Chapel in Cambridge, where supposedly the tour guide says this is the first time the flying buttresses were put on the outside of the cathedral, so it was wide open. So please, all of you, when you do your ethmoids, make your ethmoids a cathedral, all the wide open. And so if we know that works for the ethmoid in revision, please tell me somebody why you don't think about it the same way for the frontal and the maxillary and the sphenoid. If they've got disease, take it out. My favorite line, I do targeted sinus surgery. Yeah, I do targeted sinus surgery too. I target every last partition and take them out. Okay. So this creates what I call now irrigation maximized surgery. This is actually me doing this surgery. History nasal polyps and AERD, previous surgery 05, got him aspirin desensitized, returned to surgery 2012. Now he's only on irrigations and steroid. And why? I think I've got this great surgery on him that looks good, except that I blew it. He's got a little tiny interfrontal sinus septal cell right there. I'm going to find it on that side, and I'm like, oh, and then I pull out my drill and I'm drilling, and there's my little interfrontal sinus septal cell. That was terrible. I can't believe that I missed it before. Don't miss it again. Let's look at him. Here he is, years out now. Take the scope, turn it. We're going to move up to it, and there he is. If he irrigates with steroid and you've got everything open, you're going to do well. Okay, so again, looking at one more last thing for revision stuff is head position is really important. Look at the sphenoid. Don't concentrate on the frontal. Look at the sphenoid. Let's look at that again. What happens? The sphenoid's up here. It didn't get any irrigation. So irrigation isn't doing any good when there's sphenoid disease. So let's go look at the sphenoid. John Craig did this for me, took cadavers, took the brain out, put the scope in from behind in the sinuses. We got to stop that because, so you are, as if you are standing in the sphenoid sinus. This is the right sphenoid. This is the left sphenoid. This is the septum. Right side of the nose, maxillary, maxillary. When irrigation flows in, watch. It's just going to come washing in on one side and right around to the other, and it didn't even come into the sphenoid. Let's do that again. So the point is, when you have somebody irrigate and you have chronic sphenoid sinus disease, you know why? It's because the irrigation isn't reaching the sphenoid. You got to get the goods there to have it have some success. So here is another version of the same thing. And the reason why I want to do this is, you see, I'm playing with the Neomed bottle there, trying to show that you never really get that straight shot in from the sphenoid sinus. So I'm standing in the sphenoid here again, and no irrigation's getting there. So John thinks you should just turn your head back and irrigate like this. So if you've got your head nose up and you irrigate, so you got to take the little tube out of the bottle here, you flow from the bottom up and look at how you're getting the sphenoid sinus. Our CFD demonstrates that. I don't find many patients can put their head back like that. So what I do is I have them lay on the floor or outside and that sort of thing. Here we are in the OR, demonstrating again, we're packing the throat, so we're pushing that up. We're going to irrigate on one side. Here's the septum gone. So if your septum's gone, you got to have them lay flat so that they can get the irrigation back to those sinuses. Because if you've got them forward, what happens? The irrigation goes in and runs out the other side of the septum before it gets anywhere good. So when you're thinking about taking care of these revision patients, please think to yourself, not just do I need to take out the partition so the irrigation can get there, but remind yourself that the irrigation is a flood, not a fountain shooting in. And if you remember that it's a flood, not a fountain, they got to put that place where you want the irrigation. That video is terrible. I'm sorry. You got to put the irrigation, the part of their head dependent so that the irrigation will reach those sinuses. We're going to skip that. So sphenoid sinus, not reached by conventional head down irrigation. Head position can improve irrigation, laying flat in the bathtub or even outside. Difficult for patients to keep this up, but it is very true. Your motivated patients will find success and do it. So let's swing it all around. Topical therapy success is actually success in revision sinus surgery, which is actually success in primary sinus surgery, because it's really kind of all the same thing. Since cleaned out sinuses do the best for topical therapy, improve the clean out. Use image guidance if you got it. I use it every case because I want to be good. Do not hesitate to trim those middle turbinates. Make wide ostia. Draft 3 for the frontal when it's needed. And in general, keep telling yourself in your head, more radical is better, get that disease out. Now, a little bit more about other thoughts. Therapy for inflammatory CRS, which is actually all CRS. It's not a surgery or medical therapy, it's a surgery plus medical therapy. And the goal is to shift our medical treatment from systemic medications to topical treatments. So when I think about them, pre-surgical, they get systemic antibiotics and corticosteroids because the irrigations don't get there because the sinuses haven't been opened. Perioperatively, they get both systemic and topical therapy. And then afterwards, hopefully you're just systemic therapy. Topical is alone and holds them, just systemic therapy for acute flare-ups. In the immediate post-op, I give them a lot of steroids up front because I think ultimately Chronic sinusitis is all about trauma, whether it be sneezing, infection, and so on that cause trauma to the mucosa. It then swells, gets inflamed, and you have to clear it out. What's the number one trauma we do to these patients? Surgery is actually the biggest trauma. Steroids decrease that inflammation. That's why they work well. That's why I give them after surgery, sometimes as long as 1 or 2 months post-op as I transition them to local topical steroids. So bring it all around. Slide stolen from Richard Harvey. Mucosal inflammation that creates edema, mucosal colonization that does biofilm, creates mucociliary dysfunction, and access, not ventilation of the sinuses, is a key factor to treating the mucociliary dysfunction in the long term. How about AERD, the thing that used to cause us to go back to surgery and over and over and over, the true revision surgery bugaboo? 34 patients, AERD, lifelong history of polyps, 3-year follow-up, complete surgery, aspirin desensitization, steroid irrigation, 9% recurrence. We will push that number even further the more aggressive we are with these things. The regimen of complete surgery and corticosteroid adjuncts improves outcomes in a marked fashion. So in conclusion, medical therapy, CRS is predominantly an inflammatory disorder. In surgically refractory disease, medical therapy best given locally. Surgery, models of surgical gold need to be revised to improve success. Teaching, we need to get away from obstruction and talk about infective models. Future, we're going to keep in this area of topical deliverability of pharmaceuticals. Now, all that said, I love ending with this picture of me and Cohen visiting Turkey, genuine fake watches, to remind everyone that this is in evolution. This is not the end all be all. I hope that 6 months from now we'll have something new to say and that we can get even better, because yes, we've pushed ourselves down to 10%, 5% of people who keep needing work. We want to push that number further. And I also have to throw in one more timely picture. Oh, come on, it's got to advance. Advance slides. Oh no, why is it not advancing for me? There it is. And I want to thank you. These are the little people at home that aren't so little anymore. I used to say, come visit me in Philly. I don't say come visit me in Philly anymore, although I would love to have you visit me in Philly. But what I want to say is good things happen in Philadelphia.
That's right.
And with that, Troy, you're up. Thank you very much, and we'll take questions.
All right. See, I told you everyone you were going to be impressed. This was Dr. Palmer, this was an excellent presentation. Now, you got to be ready for all these questions. I mean, this was so jam-packed. It's so much. I think it was so great, we could actually probably watch it again, even though we don't have time, but it was so informative. Let's see. Let's start. What do you think about the reboot surgery?
So I used to make fun of the reboot surgery because I don't think you should strip all the mucosa. And I'm at a meeting in Christos, Georgios. Christos, thank you for inviting me. I'm at a meeting in Santorini. Next time he has that meeting, everybody should go. Awesome meeting. And I'm making fun of the reboot. Tibble Venzele's up front talking about the reboot. And then Richard Harvey gets up and he says, I got to be honest with you guys. I've seen both your surgeries. Jim, you're closer to the reboot than you want to admit. Tibble, you're closer to what Palmer's doing than what you want to admit to. So I don't want to sit there and pick off the mucosa throughout the ethmoid. I want to just leave all the mucosa that's on the bone. But it is kind of true. They probably look fairly similar. Okay. So when you say, so I would say, at least what I'd like to think I'm doing is I'm removing all the partitions and I'm doing a chemical reboot with steroids. So the mucosa I'm leaving behind, I'm removing the inflammation by oral steroids. And maybe the other side of the reboot would say they're removing that mucosa and allowing to regrow on its own in a less inflamed environment. And then we'll say we're saying the same thing.
Okay. All right. So next question. You talked a lot about the topical steroids. And one thing that I appreciate about your talk is that even though the main point was revision fest, how to be successful in revision fest, you specifically stress the importance that it's not just surgery only, right? That you have to keep in mind the aftermath, the adjunctive therapies, the topical therapy. And so a lot of people are wondering, they have a lot of questions about the topical steroids, right? So what type of side effects do you encounter, number one, and then how long do you have your patients use it?
Thank you, Troy. Easy question to answer. Number one, no side effects. Number two, forever. See, done. And then next thing you know, everybody says, wait a minute, I can't believe it, so on and so forth. Just get on PubMed and look up Richard Harvey. Richard points, thumbs up if you're watching, and then start reading the papers from there. This has been studied so well, and I assure you, oral steroids, if you use budesonide, if you use mometasone, if that's available to you, if you use any of the generations of steroids that we used in the spray, just remember probably only 5% of the steroid is staying in the sinuses, and that is probably less than what you're getting in some of the sprays anyway, if that makes you feel better. But the data is strong. It is true you should always be concerned about steroid exposure, especially if they're also doing Advair for their asthma. So your asthmatics, you want to think about that. But the flip side of all of these arguments is there is no question that topical steroids are less total steroids than oral steroids. And these patients have been getting tons of oral steroids.
So speaking of oral steroids, all right, do you still use them? And if so, what's your protocol?
So oral steroids, roughly, if it's super bad disease, I might give them a hit of steroids a week before surgery. Okay. But that also messes with our research, so a lot of times I won't. After surgery, in general, mid-sized patient, because you do have to think about it being a weight-based disease, they will get approximately 20 milligrams a day for at least the first 2 weeks. When I see them at 2 weeks, if I don't like how the mucosa is looking, I give them another 2 weeks. I'm using my endoscope to help tell me how much they need. I recognize you can argue I should be doing other parameters like taking biopsies and so on, but the look is enough. And I'll go from 20 to 10 and then 10 every other day for a week and then off. So it's usually about a month of steroids, sometimes as much as 2 months. When you start talking to individual surgeons, sometimes they're doing 40 a day versus 20 a day versus 10 a day. Steroids are really more of a global number. And so for me, 40 a day versus 20 a day for 2 weeks, 40 a day for 1 week, I think they're roughly the same.
So it sounds like, though, you do the smaller number for a longer period of time, perhaps? Did you say like a
Yes.
month-ish? And then, like in my protocol, I may do like a total of like only like a 12-day course or a 16-day course. So yeah, it can vary.
I think it's one of those 6 of one, a half a dozen of the other, Troy. But the reason why I've moved to the lower dose for longer time is that seemed to be working better than the shorter burst for a less length of time. My evidence is solely my personal evidence, and so I think each surgeon should just pay attention to your own results in the office, and then I think you kind of do what fits best.
Now, some people were wondering about your results. Now, normally as presenters, of course, we're going to pick the patients that have beautiful pictures and wide open holes, but, they were wondering during your evolution, when you're doing your draft threes, did you change the way you perform that? Like, do you do spacers, stents, flaps?
Yes. So it used to be in my early days of a draft 3, I would be kicking myself while doing it in the OR about how I was going to have to blow 45 minutes per patient in the office doing debridements to get it right. So I do rotational flaps in the OR. I use silastics, stents, but they're not really stents, they're dressings, and I leave them for 2 weeks to improve my outcomes on that. And I always love to give a shout out to Aldo Stam on this. He's the first person that taught me, leave no exposed bone. If you leave no exposed bone and you rotate mucosa over exposed bone, they will heal far, far better. So that area of septum that's coming out, I take flap, and rotate them up and rotate them in the back since the underlying bone is being removed anyway. And that seems to help me get a much better answers. And the next question, somebody out there, if they haven't, is going to complain about empty nose syndrome, atrophic rhinitis, and all those things. Don't mess with the inferior turbinates. I laterally outfracture them and don't do anything else. Frankly, it has not happened in my practice that I've seen atrophic rhinitis if you have left the middle turbinate, the inferior turbinates alone. So that's how I handle that. And I have them all irrigating, so I don't think it is a big deal.
Okay. Just going through these, making sure we kind of got most of these questions. So just to reiterate, usually the topical steroids is more of a maintenance medicine, so most of your patients will stay on it pretty much indefinitely, right?
Yes.
Okay. And then last question, how much allergic fungal rhinosinusitis do you see? I know in the United States, a lot of it is geographic, depending on the geographic region.
And so I'm geographic also, Troy. It'd be interesting whether you see this in Cleveland, because we've both done the same thing. We're fellowship in the South and then working in the North.
Right.
And so when I was in Savannah, it seemed like everybody had allergic fungal sinusitis. Right. Now in Philly, I am good for a chunk of them a year. But what I see is what I refer to as the northern version of allergic fungal sinusitis, which is every summer and early fall, a lot of these AFS people go bad, and they have a bunch of allergic fungal goop in their nose. I get it out, clear them out, give them a hit of steroids, and if I can get them to the winter when we get a cold winter, and you have a colder winter in Cleveland than we do in Philly, but once I get them to the winter, all the fungus outside dies, because when you're visiting Savannah and they say it's Spanish moss and looks pretty hanging from the trees, it's fungus hanging from the trees, and don't let them tell you anything different. And so all of a sudden, all the fungus is gone, and then these people do great, and I become this wonderful surgeon. So if I only operated in the winter, I would have 100% batting average against allergic fungal sinusitis. If I only operated in the summer, I would be like Mario Mendoza shooting 200%, 20% or something terrible like that. So I think a lot of it depends on your environment.
Well, I think that for the interest of time, I think that concludes our session. This was very impactful, and thank you, Dr. Palmer.
Thanks, Troy. It's really a privilege. Thanks, Ashok, and all the other friendly faces I see. Dr. Sama just appeared, so I better shut up and sit down and let you guys move on to the next thing.
Thank you, Jim.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.